Good evening, everyone. And today we are going to have a tough night. This is lecture number 21, I believe, or 22. We are about to finish our endometrial cancer module. We are going to finish it next in September. So we still have many presentations in the endometrial cancer module. And welcome to all our online attendees and our physical attendees. And after finishing all the introduction to endometrial cancer, the diagnosis, the radiology, I'm going to speak today about one of the most tough points for the gynecologists and oncosurgeons, at least, which is the molecular classification of endometrial cancer. And again, what I usually tell my colleagues and what I have told you in our introductory first lecture in all this presentation, that we are called oncosurgeons, okay? And this applies to even the gynecologist. The gynecologist who work as a gynecologist is called a gynecological oncology surgeon. This is his name. So it's part, we are oncosurgeons. We are 50% surgeons and we are 50% oncologists. So you must know how to speak oncology. You must share your colleagues from the oncology the same language, speak their language, and you can discuss with them in the MDTs and in any clinical context what they say. So what happens usually, again, that many gyne-oncologists and many oncosurgeons, whenever they are in a conference, in a master class, and when they start talking about the molecular classifications, the genetics, or the all the medical parts, the medical oncology, and the trials, and the drugs, they just leave the room and go to have some coffee or sandwich or something like that. And that's what differentiates a real gyne-oncologist who speak oncology as well as gyne from someone who just want to learn some surgical skills. Sorry. So today we are honored that Dr. Omar Hamdi is here with us, and Dr. Omar is one of our eminent breast surgeons. And again, I have been working as an oncosurgeon since 2005, and we have been treating breast cancer like we had a biopsy from breast cancer. We know the grade, we know the stage, and then we treat the breast cancer patients. What happened usually, up I think to 2010 or 2015, that sometimes you meet a patient who has a 5-centimeter mass, and then you do a conservative breast surgery for her, and then she has an excellent prognosis. And you have another patient with 2-centimeter mass, and you do a mastectomy for her, and then you have a very bad prognosis with a very early recurrence or metastasis. And for years, we haven't known. The same are grade 2 infiltrating duct carcinoma, for example. It is the same grade, and even it may be earlier stage, but with worse prognosis. So what happened that we had the molecular classification, and then we knew that the breast cancer is not a single disease. It's 4 diseases and more. We have the luminal A, the luminal B, the HER2 enriched, and the triple negative. And then we learned after that luminal A has got the best prognosis, and the triple negative has got the worst prognosis. And then this changed all the treatment lines. This changed all the guidelines. For example, if you have a 3-centimeter triple negative mass, you must start with chemotherapy first rather than, or with medical treatment rather than surgery. But you can do surgery first. For example, for luminal A patients, you can give Herceptin or trastuzumab for HER2 enriched patients either before surgery or after. And this changed the whole story. And now it is very basic. It is not accepted, I believe, Omar, for anyone who is an oncosurgeon or breast surgeon to do breast surgeries without knowing the molecular classification, the 4 types of breast cancer, and knowing its implication in the clinical treatment and in the diagnosis and in the decision for the treatment. So if you do surgery now without knowing the molecular profiling of your breast cancer patient, this is a major pitfall that's not accepted by any oncosurgeon or by any breast surgeon. We had the same dilemma in gynecological cancers. So we had these papers. Sometimes we have a very early grade 1 endometrioid carcinoma, and you have all learned with the pathology lecture and the diagnosis lecture that the type 1 endometrial carcinoma is a very good disease. It's a very kind disease with non-habitual metastasis and recurrences. But then you have, even in the ultra-low risk endometrial cancer, node negative and grade 1 or grade 2 endometrioid adenocarcinoma, which are the favorable types. And then you had recurrences, you have metastasis, and this made the medical societies or the gynecological cancer societies very anxious. What's happening? Why we have this recurrent pattern? So what happened really that we have what called NGS. So does anyone here know what NGS? What does it stand for? National Geographic, not just National Geographic Health. Or even our virtual attendees. So what's NGS? NGS is the abbreviation of next generation sequencing. Okay, so it's next generation sequencing. You can't work as an oncologist without knowing this abbreviation. Okay, this totally it changed the story of cancer treatment from just the routine chemotherapy and medical oncology to what we call precision medicine or personalized medicine. So, for example, if you see this group of patients, all those gray patients, if you say this is the lung patient, lung cancer patient, this is the ovarian cancer patient, and this is the breast cancer patient in the third row. We have for years treated all the ovarian cancer patients with the same medications, all the lung cancer patient with the same chemotherapy, all the breast cancer patient with the same chemotherapy. But then we knew that they have different genetic atlas and different genetic map. So you may have different patterns in the same category in the ovarian cancer or the lung cancer. For example, in the lung EGFR mutation and ALK fusion, you will hear this from your medical oncologist in all the conference. In the breast, again, it's about ER, PR, HER2 new classification. In the ovary, and we have said in the ovarian module about HRD and BRCA mutation. So in the same disease, you will find different genetic profile and different molecular profile, and then you do what we call personalized medicine, that you give the right pill for the right one depending on his genetic map, not on his disease or not on his oncological diagnosis. So there's a standard approach that you give different population. You think that they are the same, they are ovarian cancer or breast cancer, you think they are the same, but they are different. And this is now the tailored approach where you put all those ovarian cancer patients, for example, who are HRD positive in the same panel. You put the lung cancer with the breast cancer who share HER2 enriched, for example, in the same panel. And so you give the personalized medicine or precision medicine or tailored approach where you give your patient, you put all of them in the basket, not according to their disease, not according to their diagnosis, but according to their molecular and genetic profile. This is very important in diagnosis and in target discovery, in risk prediction, in the prognosis, in response of treatment, in stratification of our patient, and in drug preparation and the drug for your patient as well. Okay? This is something that you should know. Okay? I am trying that I understand what I'm saying, but don't be so tough with me. So I was born in 1981, in January 1981, and then 4 months after I was born, that was a very science or game changer. Okay? This is 1981. It was received in 1981 and it was published in 1983. So it's 2 years to publish. You know how patient they were. Okay? So just 4 months after I was born, and then 2 years to be published in Gynecological Oncology in 1983. That was a game changer paper that divide all the endometrial cancer into two pathogenic types, which are type 1 and type 2, that are well known for all gynecologists. And we know that we have type 1 and type 2 endometrial cancer. Type 1, which have been discussed in all the previous lectures, which is endometrioid, the low grade and intermediate grade or grade 2. Okay, so, and type 2, which is the high grade, the serous, the carcinosarcomas, the clear cell, and all those patterns. And again, since 1981 up to 2010, for example, or 2011, we have dividing this. This is unopposed estrogen. This is atrophy. This is on top of hypertrophic, the type 1 on top of hypertrophic endometrium. This is on top of atrophic endometrium. Type 1 has good prognosis. Type 2 has poor prognosis. Type 1 is, type 2 is aggressive. Okay, type 1 occur in the obese, diabetic, hypertensive patients. Type 2 occur in younger age and is more aggressive, where type 1 is in the older age. And then this has been discussed in all our presentations. Type 1 was 80% of cases, the majority of cases, 20% are type 2, and they are increasing, and they have worse prognosis. And then it was the fundamental framework in our discussion of endometrial cancer. We usually divide in type 1 and type 2. This is not accepted anymore. Okay, this is important. This is still to be known, but this is not the only classification. That's what has changed. Because depending on that, yes. Bafi, that's what we're going to say. Yes. It's still valid, it's very important. It's still very, we are going to say, it's still very important Okay, it's not outdated, but it's not enough alone. Okay, it's not enough. So again, it's like the breast mass. The stage is important, and the grade is important, and the size is important. The lymph node status is important, but without the molecular profiling, you lose very important prognostic data. Okay, that doesn't mean that we don't need to know the stage and the grade and everything. And again, we used to give the early type 1 uh, treatment based on traditional risk factors. Okay, for years, if you ask Khalid Gaballa, if you ask any one of our colleagues, what are the risk factors of endometrial cancer, it will be the tumor size, okay, the lymphovascular space invasion or the lymph node status, okay, and the type, if it is high grade or low grade, and myometrial invasion. So these are the risk factors that every surgeon should know. The depth of myometrial invasion, the tumor size if more than 2 centimeter or less than 2 centimeter, and the lymphovascular space invasion or the lymph node status, and the type 1 or type 2. And so we don't treat early good prognostic type 1, and we usually treat type 2, but still we have this gray zone in between. The treatment will depend on molecular profiling. Okay? What changed the game? What changed the game is the TCGA, and you must know the TCGA. Just won Nobel Prize, the Cancer Genome Atlas. So the Cancer Genome Atlas, what they have done was collaboration between the National Cancer Institute, of course not in Cairo, okay, and the National Human Genome Research Institute. They did genomic data on a very large scale that was 2.5 petabytes. Do you know how much is petabytes, Amr? We have the giga and the terabytes, and then you have the petabytes after that, okay? So it was a 2.5 petabytes of data. This is equivalent to 212,000 DVDs of information and of genomes. This is the magnitude of that, okay? In 33 different tumor types, 10 of them were rare cancers on more than 11,000 patients. And then in gynecological cancer, they studied the serous ovarian carcinoma in 2011, the endometrial cancer in 2013, cervical cancer in 2017, and the uterine carcinosarcomas in 2017. So we had now like an atlas or a map of all those genetic. And then we had this genetic map about the mismatch repair deficiency, PTEN inactivation, ARIDA inactivation, the TP53 mutations, the HER2 overexpression, and those for low-grade endometrioid, and those for high-grade and serous mutations. And this TCGA, which again is the Cancer Genomic Atlas, okay, defined 4 molecular subtypes. What they have done, that we have the polymutated, okay. So the first thing is you do the polymutation status, and we do this polymutation status by the NGS, by the next generation sequencing. This is a very advanced molecular profiling tool to know the genetic or the genomic status of your patient. It is not available in Egypt. It is not available in many countries in the region. It is not available in more than 60 or 70% of the world, and this is very important. But it is now a mandatory tool in all the high resource setting or the enhanced setting, okay, in USA, not even in all Europe, but in Western Europe and in Korea, South Korea, Japan, those only. But more than 70% of the world doesn't have this technology, the NGS technology. So you know that your patient is either polymutated or not polymutated. This is the first, which is polymerase, okay? After knowing if she is polymutated or not, okay? If she is not polymutated, you do the MSI genetic testing, and this is done by IHC. This can be done too by NGS, but it can be done by immunohistochemistry, and we have discussed the immunohistochemistry with Amani, and so you know if microsatellite instability or microsatellite stable. So the first step, you know if it is polymutated or not. If pol, so she is classified as pol. And then you do the MSI testing, and again, we are going to take this in depth. Please wait, because we are going to have this in depth in the next few slides, okay? So it is either MSI, hypermutated, or what we call mismatch repair deficient, okay? If she is microsatellite stable, MSS, not stable, we do the P53 mutation. So it's either P53 mutated, which is copy number high, or P53 wild type, okay, which is copy number low. Don't be disappointed now. We're going to have it in more details, okay? But again, we are going very basic. Amira, when we say P53 wild type, this means that she has the mutation or not? No, not. Okay, wild type is the original type. P53 mutated and P53 wild or BRCA wild, this is the original, which doesn't have the mutation. So if you have the P53 mutation, she's called P53 mutated, which is serous like or copy number high. Okay? And this has a very deep implication on the prognosis. So you see this blue line above, okay, which is the polymutated, which has an excellent prognosis. Again, you all know this Kaplan-Meier curves for all our fellows. This Kaplan-Meier curve, you start with 100 patients, and then you follow over 120 months, for example, okay, 120 weeks, over 5 years or 4 years, and then you see by the end, for example, of 100 weeks, you find all your patients are still alive. But again, if you go there to the P53, which is the worst prognosis, you find that you have lost the vast majority of your patients by, so only 40 patients from 100 were alive by the end of 120. I believe those are weeks, okay? And so the polymutation has the best prognosis, and the P53 mutant, which is serous-like, has the worst prognosis. And then you have the intermediate overlapping copy number low and MSI mutant. This is the mutation, and that was published in Nature in 2013. And of course, you know the Nature journal, okay, and how important. So again, we have this molecular classification. The ultra mutated or the very hot mutated polymutation, they have high mutation rates and hotspot mutations in the polymerase, okay, and this occur in high-grade endometrioid carcinoma. So they were high-grade before, but they have the polymutation, so they have a very good prognosis instead of being high-grade, which has usually the high risk, and it was a high risk factor. So this is the histopathology. And then in the endometrioid type, you have either MSI hypermutated due to, for example, one of them is MLH1 gene promoter methylation. This is the endometrioid, and it is usually associated with Lynch syndrome. So Lynch syndrome, which is colorectal with endometrial carcinoma. So we do usually the MSI testing in all the colon cancer, and those who work as GIT oncosurgeons know that, for example, in T2 and T3N0 colon cancer, you decide to give adjuvant treatment or not based on their MSI status, if they are mismatch repair deficient or proficient, or MSI stable or non-stable. And then you have this low copy number anomalies, which is microsatellite stable, MSS, okay, again in the endometrioid carcinomas. And then you have this copy number high, which we call P53 mutant, which is serous or high grade 2 or mixed carcinosarcomas. So again, this is the TCGA classification. This is where we divide it into poly ultra mutated and MSI. And then after that, this is done by the NGS sequencing. And then you can do the IHC and the C. By IHC, if it is MSI hypermutated, if it is microsatellite stable, it's either copy number low, which is P53 wild type, or copy number high, which is P53 a mutant, which is serous-like again, and this has the worst prognosis. And now I believe that we can ask, for example, Sahar to tell us what are the molecular types of endometrial cancer and how we do them, the testing.
We'll start testing by doing the next generation sequencing. We test first for the pol mutation. If they are having the mutation, then this is called ultra polymutated, which has a good prognosis. Polymutated, which is good prognosis. Then if they don't have the mutation, we go and do immune histochemistry for microsatellite instability. If there is instability, then this is the hypermutated MSI, which is intermediate prognosis. If they are stable, we have to do a B53. If B53 is positive, then this is serous-like, high copy number, and poor, this is the worst prognosis. And if the P53 is not mutated, then this is B53 wild type with intermediate prognosis.
Intermediate like the MSI stable, which is the same as MMR deficient. It's the same meaning. Okay, great, Sahar, really great. I'm impressed. So we had this transport consortium after the TCGA, who stated that the TCGA put insight into the heterogeneity of endometrial cancer. They are heterogeneous, but mainly in the low-risk tumors, and use expensive sequencing technologies not applicable in clinical practice. And then they did the transportic to identify predictive markers in the high-risk endometrial cancers in the high grades, and using the IHC which will ends in what we have said. It was done in France, Canada, Australia, Netherlands, and United Kingdom. Okay, so this is what we call now they changed the name of copy number law into non-specific molecular pathology. So in SMP is non-specific molecular pathology. So it's easy. We have the pool mutated, which has the highest, the best prognosis. We have the P53, which has the worst prognosis.
طب هو اللي هو شبه الهاي جريد اندوميتريويد هو مش اللي هو البيست ليه؟ هو مش البيست، يبقى الكوبي نمبر اللي هو البيست ولا ايه؟
No, the polymutated, even if in high grade, it has the best prognosis. And this is a change now in the play, okay? So it's the risk is not alone because it is high grade. It usually resembles in the pathology, it resembles in the pathology as a high grade. Yes, so if you do it, of course, it's P53 is usually high grade. P53 is high grade. So if you do it poly, this decreases the risk factors, okay? So we have now the polymutated, the mismatch repair deficient, which is the same as MSI, okay? And we are going to explain this in the next slides. We have the non-specific molecular pathology, which is not P53, not MSI, not poly. It's easy, which we call copy number low, okay? So it's called NSMP, non-specific molecular typing. This is very difficult, but it's easy because the poly, it's polymutated by NGS. The MSI is MSI or MMR deficient, okay? The P53 is P53. So the copy number low, which is intermediate, is non-specific molecular subtyping. It's easy to remember this, okay? And again, in all the data, we have the options that molecular test wasn't performed or inconclusive, which we called NOS, not otherwise specified molecularly, okay? Because again, this is not available in all the context of clinical practice. We have the polymutated, which is we call polymutant. We have the MMR deficient or MSI, which is endometrial carcinoma MMR. And then we divide into P53 mutant. And if it is not P53, not MMR, not poly, it is non-specific molecular pathology. Yes, of course. Of course. This is none other specified molecularly. Okay? Mm-hmm. Yes. If you didn't do the testing, it's called NOS. This is different from non-specific molecular pathology. Non-specific that you did the test, and it is not poly, not MSI, not P53, so it is non-specific. But NOS is that you didn't have the access to molecular testing or it was inconclusive. No. Okay? So the best prognosis happens usually with the pool mutation. Usually, this is done by NGS. It's not available in Egypt. It's not available in many countries in the regions. It is not available in many countries in the world, okay? But it has the best prognosis. Let's go to the very important point of mismatch repair deficient, MMR deficient, which is the loss of nuclear expression of one of more of mismatch repair proteins, like the MLH1, which I have said before, MSH2, MSH6, and PMS2 within the tumor cell. This has intermediate prognosis. Let's concentrate in the following because it is very important, not only for the endometrial cancer, but all for the microsatellite unstable or mismatch repair deficient in all the cancers that use the MSI instability. What's microsatellite instability or mismatch repair deficiency? Simply, we all know that we have in the DNA, we have the ACTG sequencing, okay? So we have the adenine, thymine, guanine, and cytosine. And we usually know that the C matches with the G and the A matches with the T if you go back to your secondary school, of course, ماشي? And you know all this DNA, AT, and CG, the double helix of the DNA. You will see roughly 3 billion base pairs in the sequence of your DNA. It usually appears that it's randomly distributed. However, against this randoms, you would notice short repeating sequence throughout the genome just by 2 base pairs. You'll find a repeating sequencing. Okay, we will see in the next slide. This repeating sequencing are called microsatellites. So we have the macrosatellite, we have the mini satellite, and we have the microsatellite. Okay, we don't have implication still for mini satellite or macrosatellite, but we have the microsatellite, which is the repeated sequencing of ATCG. البروجيكتور مش حلو بس هي باينه هنا على الشاشه كويس. Mini satellite. We have the macro, micro, and mini satellite. It's like the macro jeb, mini jeb, and micro jeb. Okay, the same. هو كده just to remember where microsatellite are located in inherited trait. So the scientists use this microsatellite to tell if the individuals or groups are closely related or not. What does instability in microsatellite, what we call MSI or mismatch repair deficient, means? It means that sometimes DNA breaks to replicate. Like if I remove this zipper, okay, and then I get it back, it should go back to position. But sometimes we use some specific orders. So if we have this, for example, the الشاشة هنا وحشة قوي. If we have this ATG AAAAATTC and then TACTTTGG again, and then we have this DNA replication normal. احنا عارفين, we know that with all the damage that happens by the sun, by the rays or something like that, you can lose your sequencing. But again, the mismatch repair genes will go and they do matching again. They will return the zipper in its place, and then they will have the same sequence again. They will have the same sequence. But if you have DNA replication defect, they will have not the same sequence. If you see, it's shorter now. It's shorter from the original. This is the same like this one. If you have the DNA replication normal, this is again. So this microsatellite stable. You have the damage, you have the replication or the control here, and then you have this sequence is the same as this sequence with the same number. But if you have DNA replication defect or mismatch replication defect, so this is called microsatellite unstable, and so you have this shorter defect. So it will not come back to the same order. MMR proficient and MMR deficient. So MMR proficient is microsatellite stable, and MMR deficient is microsatellite unstable. You have a problem in the mismatch repair, this mismatch, and the repair genes. So if the mismatch repair are working well, this mismatch repair proficient. So they return the microsatellites into their stable condition. So this microsatellite stable. If you have a problem in this mismatch repair genes, mismatch repair deficient, okay, so the microsatellites will not go the same as the original, and this would be microsatellite unstable. I think this is easier now. It's the same way if you miss that a button is missing in your shirt, for example. Usually you can sometimes miss that there is a button, and then you can do all the buttons again if your shirt was missing that. But specific genes will monitor the DNA for mistakes and for these missed buttons, and they will return it back, which are the mismatch repair genes. The mismatch repair genes, they will change, oh, there is a button missed here. We should return this button or bring another button and put it, and we will do repair for this mismatch, okay? So this mismatch repair genes. And this is the microsatellite instability. So if these genes, the mismatch repair genes, are not functioning, so once the damage happens, the microsatellites, they are unstable, and that's why we call the microsatellite unstable as mismatch repair deficient, okay? So it's either microsatellite instability or microsatellite instability high or mismatch repair deficient, which is against the mismatch repair proficient and the microsatellite stable. Why we are saying all of this? Why we are saying the importance of microsatellite instability, and why does this matter for cancer treatment? It's the same that you are driving across a road, if you are driving across the road, and then when you are seeing and using your eyes to see any problem or any pitfall on the side of the road, you are trying to decide if you are going to continue or to slow down and stop here because this is very dangerous area, okay? This is basically what the immune cells in our body are doing while they are circulating. They are circulating and circulating the immune cells in our bodies, and they are checking if there is any abnormalities here or there. Are there any? So one of the primary reasons that the human body doesn't fight cancer is that it doesn't recognize the cancer cells, and they see them as normal cells. So the immune cells, the checkpoints, are going to check if there is any abnormality here or there. There's something abnormal. There's something abnormal, and then they find the cancer cells as normal cells, and so they don't fight and they don't give the alert that there is something wrong. What we do by immune therapy now, and how the game is changing in cancer treatment after the chemo and radio, that the immune therapy increase the body's ability to identify that there is some problem, okay? There are some changes in the cell. So cancers that have high microsatellite instability, all those cancers that have mutation, help this effort, help this effect. That's why immune therapy is very effective in the microsatellite unstable or mismatch repair deficient. That's why you usually find the best results for immune therapy in those microsatellite unstable, because they have the genetic defect. The immune therapy and the immune system, the T cells can see, oh, there is a problem here. We have to stop. We have to repair this. And so immune therapy will do the best in the microsatellite unstable or the mismatch repair deficient cells. So is it good if we have a microsatellite unstable cancer or bad? We said it was an intermediate prognosis. Why? From prognosis standpoint, generally yes. Okay. At least since 2010, early stage cancer that have high MSI had a significantly lower chance of recurrence. This has been good news for a while for people with early stage cancer, because simply the immune system and the check cells can see that there's something abnormal in the cells and can repair these abnormalities. Before immune therapy, MSI was very bad news for patients with advanced cancer because they can mutate very rapidly. There is a mutation. The cancer cells can begin to differentiate from each other because we lack the mismatch repair gene, so we can't put the button again in the shirt in its right position. So the advances immunotherapy right now in the last few years is changing. There is very recent shift in the last few years, and now the immune therapy, we know if your cancer is MSI in the advanced stage, it still has very good chance to respond to immune therapy, and that's why all these talks, if you remember, all this media talk about the dostarlimab, for example, in rectal cancer patient with MSI, and then we had the first cure of 12 patients in rectal cancer, and this goes throughout viral, through all out the media, through the TVs, through New York Times, and through Washington Times, and all the media, even the Arabic media. Finally, we found a cure for cancer. This is a very inaccurate statement. It was a cure for those rectal cancer patients. It was only 12 patients, very small sample size, with MSI, okay, with mismatch repair deficient profile. And so when we gave the dostarlimab or the immune therapy for them, they had complete cure. Yes, this is great, but this is for a specific category, molecular profile category, and very small size, and it's very early to talk about this, okay? So that is now the revolution in all the cancer treatment. Instead of using the traditional cancer therapies like the chemotherapy or radiation, which we know as in how we had the literature of introduction to chemotherapy, introduction to radiation, they don't work specifically on the cells, but now we are going to the precision medicine or immune therapy, which kills only specific cells, what we call target treatment or العلاج الموجه للcancer cells, with much lower side effects because it doesn't go to do with the hair fall and the mucosal GIT, because it works only on the cancer cells, and we know this by immune therapy. So this is it. We can have either mutational MMR or epigenetic. It's genetic already in the genes of the patient, or epigenetic due to a change in his life from the environment or from around from the life. Okay, so we know again, like Khalid Abaziz have said in his, we have the somatic mutation and we have the genetic mutation, and you should know, okay, the genetic mutation you can find it in the blood of the patient, but the somatic is only in the cancer cells. So if I ask for you, I want an MSI sample or HRD sample or something like that, the pathologist should say, is it somatic or genetic? Okay, somatic simply it's in the tumor cells because it doesn't run in your blood, in your genetics. However, this is mostly an epigenetic change. Okay, but if you have the genetic or germline mutation, usually you have the germline, so you have the germline mutation and somatic mutation. Germline mutation, you can detect it in the blood, just in a blood sample, but in the somatic mutation, you should have it from the tumor itself because it may be found in the tumor, but not in the blood. Okay. Again, we can test for mismatch repair deficiency by IHC. This is what we commonly use. We can test it by PCR, and we can test it by next generation sequencing that we say that's a very advanced technology not available here. After that, we have again the non-specific molecular subtype, which is again why non-specific? Because it is not polymutated, it is not p53 mutated, and it is not MSI unstable. So simply that we called non-specific molecular profiling or p53 wild, because it's not mutated p53, and it's copy number low, and it has an intermediate prognosis. And the worst prognosis and the worst ever is the p53 mutation, and this is done by IHC. Okay, and then if we have p53, it have significantly worse prognosis than all other cancers. So this is again, okay, we have a very important say in Egypt, which is التكرار بيعلم الشطار، وفي مقولة أخرى التكرار بيعلم الحمار. Okay, so it's polymutated, mismatch repair deficient, p53 wild type, and p53 mutant type. Does this have implication why we are going through all of this? Simply, I have said the same presentation 2 years ago in 2022 in the same auditorium, in the same place, but I didn't have those slides because simply we don't have this implication of molecular on the treatment. But now we had this 2023 FIGO classification, so the new classification. The first was in 2018, and then we have the 2023 classification, and it totally changed the game. Now the molecular profile enters into the classification. Okay, so we divide it into non-aggressive histological subtypes and histological subtypes, okay, and high-risk aggressive histological types, and with this aggressive histological types, and it started to go the aggressive, the subtype, if it is serous, if it is endometrial, if it's something, it started to go into the classification. But again, this is for the aggressive types, the serous, the clear cells, the carcinosarcomas, not about the molecular classification. Okay, this is about the types. But you have a complete change in the game right now. Okay, and then you have the risk stratification. So, for example, I was with Muhammad Hamdi just 30 minutes ago, and I asked him, if you have, for example, Dr. Muhammad, a case of serous carcinoma in the uterus, and it was invading more than half of the endometrium, what stage it would be? He said it's 1B, as we have said for years in this place. But now, no, simply it is stage 2, because this aggressive histological subtype was myometrial invasion. So once the serous type do myometrial invasion, even if less than half, it's stage 2, not stage 1. Again, we had these patients with ovarian and the uterine endometrioid carcinoma, okay, that have been usually staged as stage 3. Now we can stage them as a stage 1, okay? But the problem is that now we do the risk stratification. If the molecular classification, again, the risk groups are divided into low, intermediate, high intermediate, and high, according to the status, if they are molecular classifications unknown or molecular classification known. So once it's, for example, polymutation, this is a low risk group. If she is P53 abnormal, this is intermediate risk. If this is stage 1 to 4 P53 abnormality, endometrial carcinoma, myometrial invasion, this is high risk. Again, next presentation would be Khaled Gaballa next week about the surgical treatment. And then after that, we have Dr. Ghada Izzat, who is going to speak about the adjuvant treatment. The adjuvant treatment is done according to the risk stratification. So we stratify into low risk, intermediate risk, high risk. All 4 years we have used the molecular classification unknown. It's about the stage, the grade, and the lymphovascular space invasion or not. It was this only the risk factors. But now we use all this molecular classification. This would be going to be discussed thoroughly in Dr. Ghada presentation. Yes. Yeah, B53 abnormal is B53 mutant, is B53 type, which is the worst prognosis. If it is normal, it is B53 wild, okay? Again, we have those series of very important PORTIC trial, which are very important for our clinical and medical oncologists to know this PORTIC trial. This PORTIC trial is a long series that started in 1993 to 1997, and it was published then in 2000 about the role of external beam radiation therapy in endometrial cancer. So before the year 2000, there was no rule for radiation therapy in endometrial cancer. It was an only surgical disease. But then the PORTIC 1 in the late 1990s, and then published in 2000, it entered the external beam radiation in endometrial cancer. After 10 years, they discussed the brachytherapy with external beam radiotherapy, and then the PORTIC 2 trial has added the value for brachytherapy with external beam in many contexts in endometrial cancer, and now it is routine to use brachytherapy with external beam in the high risk categories of and the intermediate risk endometrial cancer. And then PORTIC 3 was published 4 or 5 years ago about the adjuvant chemoradiotherapy, about the addition. So it was just treated in all endometrial cancer by surgery, and then we added the external beam by PORTIC 1, and then we added the brachytherapy by PORTIC 2, and then we added the PORTIC 3, the adjuvant chemoradiation therapy, and all of these are randomized controlled trials. This is stage 1 evidence-based medicine. Okay, there's a change the practice. And now PORTIC 4A is ongoing. We haven't published. What they are studying the effect of molecular profiling on the adjuvant treatments. So this is going to be changed in the next few years. That's why I'm seeing that the journey is changing, and you are enjoying it. When I give this lecture in 2019, it was something. In 2022, it was another thing. And now in 2024, we have the PORTIC 4A trial. I hope that we have ربنا يدينا الصحة يعني والعمر إن نقول المحاضرات دي في 2026 with the results of PORTIC 4A and then going to PORTIC 4B, and I don't know why they subclassified it into A and B and C, بس هم بيحبوا يعقدونا في عشتنا. Okay, this is the clinical trial.gov. PORTIC 4, it's molecular profile based versus the standard adjuvant radiotherapy in endometrial cancer, and this is the new what's happening. Okay, and they divide it into the chemoradiotherapy or blah blah blah. All this will be done in a few years. It is rainbow, not the rainbow that you know. The colors are شبه rainbow, but it is not the rainbow that you mean. Okay, there is no W. Okay, and so in the ESGO/ESTRO ESP guidelines for management of patients with endometrial cancer, now we divide all the recommendations. You divide if you don't have molecular classification is unknown, or if the molecular classification is known. So you do the polymutation, and it has its own clinical implication in the risk stratification and then in the adjuvant treatment that should be discussed in details with Dr. Ghada 2 weeks later. This is the intermediate risk again. You are speaking about the P53 abnormality carcinoma if it is restricted to a polyp without myometrial invasion, so you give adjuvant therapy. Okay, or adjuvant therapy is not recommended in this category. So you should ask about the polymutation, the P53 abnormality, if you have the access for this. The high intermediate risk again is divided if lymph node staging performed or not performed, and so you divide all the stages according to polymutation and all this. Okay. So the Europeans, not us, not anyone else, have said that this use of polymutant NGS first approach is very costly. It is not applicable for all people. It is not found in all Eastern Europe. Yes. Yes, and in low grade and yes. ماشي. So they developed a novel algorithm, okay, to decrease as much as they can the need for doing the next generation sequencing, okay. So they start first by the MMR and MSI, and then they do after that the V53, and they keep the polymutation at last step. So at least if you don't have the polymutation, you can escape it, and it decreases the need of doing not approaching the strategy by the poly first, which is very high and very costly. So you don't have to do it for all population because it has a very good prognosis. It will not affect the treatment some while, okay. While the P53 will affect the treatment, you will add some treatment because it has worse prognosis. So they start first by the IHC, the MSI or MMR, and then they do the P53, and then they can do the poll at the end, or they can do, and this decrease really the use of P53. They say here that decrease P53 by 27%, and they decrease the polytest by 67%. So we don't have to be shy when we speak about resources and about keeping how to save our money, because all the world work about this. Again, this is different in target therapy in the advanced cases. So those post MSI stable and polymutant subtypes express immunogenicity, okay, because of high mutation. So the addition of PDL1 or anti-PDL agents like atezolizumab or nivolumab or pembrolizumab can be effective in recurrent or metastatic MSI or polymutant endometrial cancer. Simply, now we have in the issue of metastatic and recurrent endometrial cancer, this would be discussed with Dr. Khada. Now it is a very good and hot place for the mismatch repair deficient almost to do the pembrolizumab for advanced endometrial cancer, okay, واللي هو بنسميه كترودا. Okay, so it was first approved in 20 and then 2022, and then now it is approved even for mismatch repair proficient, but it changed the game. So if you have the access, if you can have this immune therapy, if you can have the pembrolizumab, okay, you would ask your patient of the recurrent and metastatic endometrial carcinoma. It would help so much, especially in the cases of mismatch repair deficient or microsatellite unstable. So simply, this report was written today. I wrote this report today. I had this patient with recurrent high-grade endometrial carcinoma, and she has a stump recurrence invading the vagina and invading the vagina and the urethra, and she was referred for me for doing surgery. So I wrote for them that she is 74 years old, and she had an optimal surgery 2 years ago, but she didn't have her post-operative radiation because she had some operative complications that necessitated she to have 3 consecutive operations. And then by examination, now we have a large mass, stump mass 7 centimeter, invading the whole vagina, and the clinical examination, the vagina and indenting the urethra. So I told them that surgical solution would be anterior exentration, okay, and total vaginectomy, which would be very morbid for the age being because she is 74 and obese patient with PS1. And I asked it for age being she can have chemoradiation. It would be alternative, less morbid than surgery, and she hasn't received radiation in the first context, so she can have radiation. Now we still have the card of radiation, which can do a good job here, but not as neoadjuvant, as definitive treatment, chemoradiation. And then I wrote for them that palliation was discussed too, that we can keep her just on palliative treatment, but I will not recommend this because she has a good general condition and she has isolated recurrence non-metastatic and may give good response for therapy. And that was the last line that I wrote, that MSI testing and PDL and then addition of immune therapy can be a good solution too if this is not going to cause financial toxicity. If she can afford, لو في شركة cover it or they are well to do. So if not causing financial toxicity, we will add this. So this is what happened when you are aware by all the game cards. Okay, you have all the cards, you have GIL, and then you wrote the second opinion report, not for surgery, but this is what you do for them. The future is that it can be used too for early detection and in surgery. What's the implication? We are all surgeons. احنا مالنا بكل الكلام ده. it can help in our decision in doing ovarian preservation or not, because as we can imagine that the ovarian preservation would be very good with polymutated tumors with some sort of MSI, but it will not be good for P53, for example, to preserve the ovaries. What about fertility preservation? I'm going to present next in September, the second week of September, about all the fertility preservation in the ESGO ISHRI guidelines that was published in 2022, late 2022. Now we add that we know all, I think that you all know now, fertility preservation is for low-grade tumors, grade 1, maybe grade 2 sometimes, with no touch of the endometrium, no invasion of the endometrium, not 50%, with no touch of the endometrium, okay? That's totally removed, and you don't have any residual inside. And then this was the criteria that we depend on, that you have a tumor, endometrial, low grade, stage 1A, not stage 1A, but no touch of the endometrium at all, and then you can remove it and then put the Mirena loop and give the oral progesterone. But now they added that you have to do immunohistochemistry to identify the mismatch repair deficient tumor, okay? And if you have to exclude Lynch syndrome before counseling the patient for having additional cancer, for this individual cancer patients. In a tumor with P53 phenotype, testing for MSH or polymutation should be considered to develop if the tumor belongs to them. In women harboring copy number high P53 abnormalities, conservative therapy would be inappropriate. So this is how it now affects our decision. So 2 years ago, we didn't have to do the 53, but I had this patient from Alexandria 3 weeks ago, and she came with me with grade 2, stage 1, non-myometrial invasion. And I told her, yes, you may be a candidate for this, but we should do a hysteroscopy first. We are going to discuss this next month in details. But the new thing that I did that I haven't done, for example, for my last 2 patients last year, that I asked for the MSI and P53 status, okay, and which are available in Egypt, of course, to do by HC. And if she was P53 mutant, I wouldn't consider conservative surgery. So this is how science, it changed our decisions. This is how everything changes our decisions. So I know it was a long, very tough presentation. Amr is feeling so disappointed, okay? But the take-home message, Amr, that the new and it is no longer new molecular classification should be known by all specialties related to gynecologists, either the pathologist, either the radiologist, and the surgeons and the gynecologist. It has been already implicated in the clinical practice, okay? And we will have and need time to be resources compliant because it's still valuable in the resources. And will it change the surgical practice? This line, I was just saying maybe 2 years ago, but now I changed this line in my modification this year in 2024. Yes, it started to change our surgical practice for the ovarian preservation and for the conservative treatment. And a very important word that we all know, that no one size fits all in anything in life. No one size fits all, okay? Mainly in oncology, no one size fits all. I believe this is Amr's face now. This is our face. I hope it is not like this, okay? And finally, I hope to meet all of you in 12/12/24 in Cairo for the Let's Go Egypt. And thank you so much. I'm waiting for all your presentation. أتعشم تكونوا فهمتوا حاجة يعني. So if anyone has a question, we have a question in the Q&A box. Laila is called next generation sequencing. Okay, Laila, we answered it. Thank you. So
what about dual mutations? يعني can it happen?
فهمت حاجة رضوى من القصة؟
That is very clear صراحة. It's very nice.
Very clear. يعني خلاص يعني it's very clear دي كده أنا أروح بيتنا مبسوط بقى.
بس عندي سؤال، ممكن تحصل dual genetic mutations صح؟ وفي الحالات دي بتعمل إيه ومين بيجي مع مين؟
تاني مش فاهم
يعني ممكن يبقى عندك poly و P53.
No, mostly once you have the polymutation, it's polymutated. Okay, دي superimposed دي خلاص. Once it is polymutated, okay, yes, you don't do poly MSI something like this. So it's one poly, it's alternated, it's poly. Okay, it's polymutated. So
مش قصدي ان احنا بنبتدي الالجوريثم
يعني.
من فوق من تحت لفوق زي ما انت قلت، يعني بنبتدي MMR وبعد كده
with the polymutation, this is for the rich people, and for us we will start first with the mismatch repair and then the P53, and then we don't have the poly to put it in the last of the panel.
ماشي. طب لما بتوصل للبي 53 do you have to do pulley because that will change prognosis ولا بتقف هنا وخلاص؟
Up till now على ما انا بقرا في حاجات الجراحه at least okay we don't have a problem to add poly because poly is a good prognostic so you can do it, but those who are going to change our decisions really are the MSI and P53. So if I'm going to do, for example, a resource oriented or resource stratified guidelines for Egypt, for example, I'm going to say that if you have the capacity, ask for MSI and P53. We don't have to ask about poly. We will not pay for doing next generation sequencing unless you do it for other cancers. But we can be satisfied now only with MSI, with p53, which are already present in Egypt.
Thank you, Dr.
Ahmed,
Basel. I'm Ahmed Sudan. Thank you for this fruitful and actually organized and to the point lecture as usual. The
معلش صوتك
question
يا أحمد بس
is
شويه عشان صوتك بعيد شويه.
السؤال بس يعني حضرتك جاوبته ان انا يعني ممكن I escape البولي and I start by MSI, but as you know, B53 is more popular in Egypt than other tests. So can I start by B53?
Usually you start by the MSI and then p53.
MSI test in Egypt, is it
Available, yes,
available?
available in Mansour and available everywhere because we use it for the colon cancer, very common, and for many other cancers as well. So the mismatch repair is present in even in the private labs.
Okay, so I should start by MSI according to our resources.
Yes, and p53 can be done as well.
Okay, thank
So
you.
what I mean that now when you have your endometrial cancer sample, as you do in the breast, that you ask for ER, PR, HER2/neu, and Ki67, you should ask for the endometrial cancer. For the p53 and the MSI status, you should ask for them. Some people would like to ask about the ER, PR status, and the new thing that you will ask about the HER2/neu, because we have now we have now the Inheritu, which is a new drug that's going to be in endometrial cancer for those HER2 enriched endometrial cancer. So قريب جدا هنطلب الHER2 again endometrial cancer patients.
So this is with DNC biopsy.
Yes, or in the final hysterectomy. No, انا كان في سلايد حاططها على الcoordinates between the DNC and the final pathology, and they are usually coordinates. They are usually the same in the molecular profiling, the DNC, but you don't have to ask for the molecular profiling except when you do the final hysterectomy. But again, because this will change the fertility preservation in some situations, in the ovarian preservation, so you can do it, of course, in the hysteroscopic or the DNC biopsy as well from the start, but this will delay your patient. Dr. Omar will ask a question, but yes, I believe that p53 will have some sort of chemosensitivity because it's serous carcinoma, it's high grade, okay? So as it is a high grade tumor, it will be more chemosensitive, okay? So that's why, but it will not change up till now to have new adjuvant, for example, p53. This may be the future. This may be in 2030 or 2025 in the medical oncologists مش هيسيبونا في حالنا، هم يفضلوا يدوا new adjuvant في كل حاجة لحد ما نبطل يعني. But up till now ما فيش قرار new adjuvant based على molecular profiling. But chemosensitivity usually in the high grade tumors.
Does it make a difference إذا عندك high يعني early cancer أو advanced؟
What?
يعني molecular profiling mainly الرول بتاعه في early cancer صح؟
In both in early and advanced as well. في الادفانسد زي ما اتفقنا الام اس اي ده هو mainly دلوقتي في الادفانسد تعملي ام اس اي علشان تاخد الاميون ثيرابي اور نوت to benefit from the immune therapy or not. اوكي. دكتور هشام ابو طالب.
السلام عليكم. Very marvelous presentation as usual from Dr. Basel. And my
بس.
نعم؟
هي مارفلس عشان حضرتك موجود بس.
لا يا فندم ازاي؟ ما نقدرش. هو السؤال بتاعي دلوقتي will molecular profiling direct the surgery? For example, if we have p53 mutation, are we going to do surgical staging with lymphadenectomy up to the para-aortic lymph nodes and omentectomy? Or this still has no role in surgical aspects of staging of endometrial cancer?
Yes, this is a very good question, Dr. Hisham. Really, what's ongoing is that we are omitting lymphadenectomy step by step in endometrial cancer. So what we call about the lymph node surgical staging is now going to be much more about summer sentinel lymph nodes, okay, endometrial cancer. So in the low risk, you don't have to do the lymphadenectomy, but in the high risk, you can do only the sentinel lymph nodes, and if they are positive, she will have adjuvant radiation. Okay, you don't have to do lymphadenectomy. So we are going to omit step by step. Dr. Khalid Gawalla, I believe, is going to discuss this in details next week, but we are going to omit the lymphadenectomy from the whole process in the next few years. If you have the access to do sentinel lymph node, so do it. If you don't have the access to do sentinel lymph node, the p53 is serous-like, so of course it is high risk by default. And again, so you have to do a p53 mutant lymph node dissection, which is serous type because it is like the serous carcinoma, which we do now lymphadenectomy for hair. But mostly as the progress will happen in the molecular classification, we are going to omit the lymphadenectomy from gynecological cancers. But do it till now based on the IHC and histopathology, not molecular profiling. And this will be a very hot area for research in the next few years, by the way يعني. دكتورة حنان حجازي معانا اونلاين. دكتورة حنان، انت فهمتي اي حاجة من اللي احنا قلناه؟ ولا بتكلمي أميرة بس؟
هاي دكتور.
هاي حنان.
والله very complicated lecture، يعني لسه بقول لأميرة محتاجة أسمعها على 10 مرات. يعني
Thank
I'll
you.
divide it 10 minutes 10 minutes 10 minutes عشان يعني مخي يستوعبها بسرعة. Maybe by next lecture أكون لميتها.
اوكي، ما هي أميرة ظلمتك ان اول محاضرة تبقى دي اول محاضرة، حرام يعني.
لا أنا عندي فيلم بحضر، بس هي
Hmm.
محتاجة.
Dr. Handy Ezra from Turkey, was it easy or difficult? Dr. Handy is not here. Okay, and finally, I want to hear some of our medical oncologists, Dr. Layla or Dr. Maya Abdel Nabi, some one of our medical oncologists, لأن هم بالنسبة لهم الكلام ده أسهل بكتير من بالنسبة لنا. So Dr. Maya, if she wants to say, or Dr. Layla.
Hello, it's past so difficult, and thank you for your presentation.
ده مين? Who is talking?
This is Hande Esra.
Oh, Handy Ezra. So you understood it? It was easy? Turkey.
After your presentation, yes, I can say easy, but at the first, that was so difficult, I think.
This is great. Thank you, Andy. Really, this is a good. Laila or May wants to say something. Any comment from the medical oncologist? So no comment. Yes, May.
Good evening, Dr. Basel. It was really a very informative presentation. It is difficult for all of us, even for medical oncologists. It took us a lot of time to digest the new classification, and we're trying to get used to it and incorporate it in our daily practice.
Great, great, May. So thank you all. It was a difficult job for me to prepare this one, really, but I have prepared it 2 years ago, so it was more or less easy job now. And it would be, I hope ان انت نقولها مره واثنين وثلاثه لحد ما نحفظها. Polymutated,
Exactly.
MSI, and then the non-specific nuclear subtyping and P53. And for this, next week we are going to have a much easier presentation by Dr. Khalid Gaballa about the surgical management of endometrial cancer, and the week after it would be the.
Basel, I think احنا دلوقتي for molecular profiling we will not do polymutation.
ما عندناش اصلا.
ما عندناش اصلا.
ما
فاحنا
عندناش
هنعمل
ما عندناش NGS technology. You have to do it overseas.
فاحنا هنكتفي بالام اس اي والبي 53.
Yes, yes, please do this. So we'll just finish and complete now, okay? We will have to do ERPR. Sometimes it is not mandatory, but you can do ERPR for hormonal treatment in some context, and we'll discuss this later. So it was a long hour. Thank you, a very condensed hour. Thank you all. It's a pleasure that many of you have understood. And see you next week with Dr. Khalid Gaballa, surgical management of endometrial cancer. Good night.